chairperson, expert panel, and all of my dear friends and senior teachers. Today I am going to talk how do I tackle difficult PTMC with in front of my legend master, Professor S.K. Dwivedi. And it's always pleasure to discuss PTMC with Professor Dwivedi. So when we all know that the PTMC is the standard of procedure of choice for the isolated rheumatic mitral stenosis. But when we start the procedure, we can face challenge start from the puncture site by the septal puncture, local site puncture with the crossing balloon to LV, and after that the particular anatomical substrate. So I will discuss all these in few slides. So first of all, difficulty in septal puncture. Septal puncture difficulty can be due to the large LA, due to the thick or calcified interarterial septum, due to the aneurysmal interarterial septum. These are the possibilities which can cause the problem. Particularly in case of the large LA, we can negotiate the problem by the increasing the angle of broken bone needle and probing entry in the left atrium. So this is the case. You can see that the whole of the heart occupied by the LA. It's not large LA, it's a giant LA. And we taken the shot from the RA is just covering up the LA. And we try to position our needle in almost all view, but finally we identified a curve of the LA in lateral view and try to enter in LA with the probing of needle. And this one is the second case. We try to puncture, and secondly we try to strain our septum, and there is a vertical dissection. It's a usual thing. It's nothing abnormal. We have to confirm that we didn't puncture our aorta or root. If it's happened, it's giving you the marker to further do your puncture, and in this case we again increase our broken bone needle angle and successfully complete our procedure. Second problem is difficulty to how we can manage our patient with the difficulty in septal puncture. We can go for the another side of puncture. It's really difficult. No one ideally doing this. And another thing is that you can go with the another wire in LA, pigtail wire, increase your support and then push. So this is the third case in which we try to puncture it, and this is the patient who had thickened septum. We try to probe it, could not be succeed. And then in third image you can see that we try to puncture it with the help of the needle, but we push it very hard, but could not be able to negotiate. And after that we again increase the angle of our broken bone needle and then push it and complete and successful with the puncture. Again, next step is the septal catch. Whenever you have the septal catch, you have to dilate your septum again and again with the larger dilator. You have to increase your support by the advancing your stellate. You have to increase your support with the looping your balloon in the LA. Difficulty crossing involved. It's a reality. Almost all of us facing this situation, and we can negotiate with this problem by the changing our stellate loop. We can change by the over the wire technique, by the catheter sliding method, and again the straight balloon technique. So when we have a small LA, we have to reduce our stellate angle. If we have the large LA, we have to increase our stellate angle. So this is the first case in which we did the PTMC. I think it's the largest LA we ever deal with. And if you can appreciate, this is the loop, and it's the huge loop we have to make. And this is the second case with the small LA, and we try to hairpin entry in this case. And if everything fails, large LA, you can go for the reverse loop entry. You can make the reverse loop with the help of the pigtail wire, rotating it clockwise. And whenever you enter with the help of the reverse loop entry, please ensure before dilating your valve, you are going freely up to the apex of the LV and ensure that your entry is not through the chorda. Again, the anatomical variation, calcification, we all know calcification of mitral valve deteriorates our result, can cause the acute MR, can cause the embolization or suboptimal result. Bilateral commissural calcification is absolute contraindication. Unilateral commissural calcification can be done successfully, and leaflet calcification with gray commissural give good result in our case. And this is the case where we did. Definitely it look like a MAC or mitral annular calcification, huge calcium all over the annulus or leaflet, and see the patient of 34 years presented with the failure, took 3 or 4 days to stabilize, and we did the gradual dilation and have the wonderful result, and we are following patient last 3 years, she doing well. Again, problem with the subvalvular disease. Subvalvular disease, usually we could not achieve good result. We can cross our balloon, but unable to pass balloon to the apex. And whenever you suspect the severe subvalvular disease, sometimes you need to cross the balloon with the help of the over the wire technique, sometimes to use the extra support, and sometimes it may be required to have the peripheral balloon first dilate the subvalvular system and then dilate the valve. And in this case, we did the gradual dilation with increasing 1 or 2 ml of contrast, and ultimately have the good result with the severe valvular disease. Left atrial thrombus, as Professor Manjunathan done the excellent work, more than 108 patients in which they deal the patient successfully with the LA appendage clot or a clot in RA roof, LA roof which not crossing the fossa ovalis. And these kind of cases can be attempted with the low IS septal puncture with the over wire the technique. So this is the case with has the LA appendage clot which is protruding. We did this case by after the anticoagulation for 3 months, crossed the pigtail wire with the help of Mullin sheath and taken the balloon and successfully dilated and had a good result and without any complication. Pregnancy specific situation, we all know that we day by day facing these kind of patient, and we have to deal this this disease in these kind of the patient, and we all know that the 12 to 20 week is the extreme potential time for the vascular changes, and we have to deal any time of the pregnancy, ideally after the first trimester, and should be at the 20 to 24 week, but whenever need arises, we can treat the patient. Should do this patient in first or second case. Don't wait for a patient for long time fasting. Complete your procedure as soon as possible. Never try for the best result, suboptimal result, well accepted, and go for the without MR is your priority. So, and very simple procedural detail is required for the pregnancy. You have to cover your patient from back with the lead apron and anteriorly with the lead apron, and without doing any LV angio, RV angio, hemodynamics, just cross the valve and with minimum radiation complete your procedure with suboptimal result. Transjugular PTMC may be required some venous congenital anomaly or in the acquired anomalies. Usually septal puncture done in RAO 45. It's a simple procedure. It's the only puncture which will be difficult for these kind of patient. LV angiogram always helpful. Entry in the LV is easy, and if it's difficult, we can use the over the wire technique. And important is for the jugular PTMC is our needle position is 7 to 8 o'clock position, and nothing specific for, other than that. PMB in dextrocardia, we did it in 2 cases, not very difficult. Image immersion in newer cath labs is very easy to do these kind of cases. Again, needle position in 7 to 9. All movements should be done in opposite direction, and MB crossing in the LAO, which is the pseudo RAO view. Cardiac tamponade, definitely true, and it maybe happen anytime. So always have the high suspicion whenever you do the puncture and any hypotension or any hemodynamic instability, go for the echocardiography. For needle puncture, if they are the only simple needle puncture, wait and watch, and if there is no tamponade, go for the complete your procedure. If septal dilation done and then patient develop the tamponade, please put your dilator across the septum. Manage patient by the pericardiocentesis, and if not improving, shift the patient to the surgery OT with the dilator in place. So this is the case. Whenever you have a pericardial tamponade in patient, please analyze your patient carefully. You can identify any time that you did something wrong. So this is the case. You all can identify what we did wrong. And patient, as we puncture our patient develop hypotension, echo given the pericardial tamponade, we drain the patient and complete our procedure successfully. Patient doing fine and discharge the second day in hospital. And lastly, this is the part and parcel of our procedure. Whatever you try, whatever meticulous you are, you can have this complication anytime. So please assess yourself again and again and try to minimize this. And whenever it happens, go for the surgeon's help. Don't try to manage patient conservatively. Thank you. Thank you very much.
Nice presentation.
Raja sir.
Yeah, Dr. Hazra, please. Go ahead. Sir.
Can I make a comment here?
Sir.
Very nice presentation, quite impressive. Now, you know, it seems like a historical cases in 2022 when you have imaging. Heart is never a two-dimensional structure. What you do on a fluoroscopy is a two-dimensional thing. When you have access to TE, most of the difficult cases can be done on TE within 2 minutes. So why you put patients at risk? These are the student days in VMB cases we used to do. So why don't you upgrade, stay ahead of the time with the TE to avoid complications in human life? Second, you know, I might ask you a question. Which view you take for pericardial drainage? Is it the position of AP view or you take a lateral view? Which position you think is the best view to do the pericardial?
For sentences.
Pericardial sentences.
AP view, sir.
Why?
Yeah.
Since a lot of students are listening, best view to do the pericardial aspiration is to go lateral. You take a small dye in your 5cc syringe and keep on tracking this dye until you reach the pericardium. AP view can never make whether you enter RV or AP or, but lateral view behind the sternum, you know there is a pericardium, there is a white space, there is a fluid, then this epicardium comes. So go lateral. Thank you.
Yeah, that's the time that we have, Mr. Chairman. We'll have to move on to the next presentation.
I think.
Actually, but I just like to comment on the TE. Actually, we tried some patient with the TE, but when we historically compare our data and our result with the TE guided puncture, it's very difficult for our patient. It's very painful, and surprisingly, I can comment that we didn't have any unfortunate event with our patient on fluoroscopy, and we are much comfortable with the fluoroscopy without TE. But definitely, it's another modality. We should incorporate this, but we tried, but we couldn't able to convince ourselves and our mentors.
Okay.
Thank you.
That's the followed by 2